So right now we're going to talk a little bit more about sarcomas and how we treat sarcomas in 2026, specifically regarding precision oncology and the new targets that have emerged in sarcoma. I'm Elise Nassif Haddad, and I'm a sarcoma medical oncologist at MD Anderson. The way I've laid out the presentation is first we're going to talk about recent FDA approvals prior to the year 2025, then focus on the novel targeted drugs for which we saw data in 2025 and for which there will likely be access in the United States at least for the treatment of sarcoma in 2026. Then I'll move on to novel targets under development that were presented in 2025 and for which we'll be waiting on new data to be presented in the next couple of years. And then I'll wrap up on a summary slide of what has changed in clinical practice in 2025. Moving on to the recent FDA approvals in sarcoma prior to the year 2025. Amongst others, those I thought were useful to emphasize in this presentation pertaining specifically to precision oncology was the approval of Nab-sirolimus, specifically in PEComas, NTRK inhibitors, of course, Avapritinib, Avapritinib, and others in NTRK translocated sarcomas. The use of Crizotinib in inflammatory myofibroblastic tumors, Avapritinib in just harboring PDGFR alpha D842V mutations, or the use of Tazemetostat in epithelioid sarcomas. In 2024, before last year, we had 3 major FDA approvals. One for Atezolizumab as first-line treatment for ASPS, alveolar soft part sarcoma. One for Nirogacestat for desmoid tumors. And finally, the first modified TCR-T-cell therapy ever approved by the FDA was approved for synovial sarcomas. And now moving on to what happened in 2025 in terms of novel targeted drugs for the treatment of sarcomas, which you will likely be able to use in the clinic in 2026. One of the most impressive articles, abstracts presented at ASCO in 2025 during the oral presentations was that of the use of Abemaciclib in patients with Kaposi sarcoma. Dr. Ramaswamy first presented some intriguing data on preclinical data showing in infected cell lines infected with KSHV that those cell lines were highly dependent on CCND2 and CDK6, and that the use of Abemaciclib increased expression of immune cell surface markers in these infected cell lines. The study design was quite straightforward, with a short phase 1 using a 3+3 design, starting with dose level 1 of Abemaciclib 200 milligrams BID. Abemaciclib is a drug that's well known in other tumor types, so the phase 1 was rightfully very short, and then a phase 2 with 2 cohorts, one with patients having had prior Kaposi sarcoma therapy, 17 patients enrolled, and a phase 2b in patients who were not previously treated, enrolling 11 patients. The adverse events were really as expected from Abemaciclib, as we know, mostly consisting of neutropenias and diarrheas, which were manageable, and some creatinine increase, all within grade 1 or grade 2. Waterfall plot speaks for itself. Amazing response rate, and specifically even in those patients who didn't reach RECIST response, almost all patients did have some form of response. All participants together had 84% response rate. Patients who've had prior Kaposi sarcoma therapy had 81% response rate, and those who didn't have any prior therapy, who were treatment naive in first line, had a 90% response rate. So the key takeaways for this presentation were that Abemaciclib provides a safe and novel T-cell sparing option with a response rate of 84% in patients with Kaposi sarcoma. The preliminary mechanism of action of Abemaciclib may be effect on cyclin D and Kaposi sarcoma herpes virus induced viral cyclin expression. There are limitations, of course, since this is a single center study. This study likely makes Abemaciclib available as off-label in the U.S. There is still the NCI study, which is actively enrolling, and referral to patients is encouraged. Second very interesting abstract, also presented at the oral session at ASCO in 2025, is the use of off-label trastuzumab deruxtecan in desmoplastic small round cell tumor, presented by Dr. Slotkin. We've known for a while now in the sarcoma community that those DSRCT tumors had higher expression of HER2 than other tumor types. However, what we didn't fully appreciate up to this article was the discrepancy in looking at HER2 positivity through IHC clones and how much this differed from one clone to the next in patients with DSRCT, and how it wasn't at all always correlated with the transcriptomic expression of HER2. Importantly, what this abstract showed was that all 16 patients who were treated off-label experienced some form of clinical benefit, so it does seem like TDXD did bring some clinical benefit to 100% of patients with a confirmed either stable disease or partial response, and very impressive 50% overall response rate using RECIST. So this was really interesting data that we had been waiting for a long time in the sarcoma community. Importantly, based on this data, early off-label experience suggests favorable TDXD and DSRCT, and so off-label prescription of TDXD has been expanded based on this data. It's really important to say that out of the 16 patients who derived benefit or not all of them had either IHC nor RNA-seq expression of HER2, and we don't fully understand what is the best biomarker to use for prediction of response to this drug. Important to highlight that there is a planned COG trial for enrolling patients with DSRCT with TDXD. Moving on to GISTs, and this particular design and data of the PEAK trial of sunitinib plus bezuclastinib versus sunitinib alone in second-line setting is actually a slide that dates from 2024, where we started to have preliminary data on the PEAK trial. And so in 2024, already we could see this quite impressive waterfall plot and response rate with an objective response rate of 27.5% in all patients and 33.3% in the patients who were treated with prior imatinib only. The median PFS in second line of the PEAK trial presented in 2024 was 19.4 months. And what we saw this year was a press release from Cogent Biosciences sharing that the median progression-free survival was 7.5 months for bezuclastinib and sunitinib compared to 9.2 months for sunitinib monotherapy in this trial. There was a 46% objective response rate for bezuclastinib combination compared to 26% for sunitinib. The safety profile was well tolerated with no unique risks observed with the combination. And this is literally the first positive phase 3 trial in second-line GIST patients in over 20 years. So we are quite excited about those results. Mechanism of action for bezuclastinib is a targeted KIT inhibitor on exon 17 mutation, and there is now an expanded access program for the combination of bezuclastinib with sunitinib. Moving on to chondrosarcoma, and the new death receptor 5 agonist was a KIPART in conventional chondrosarcomas. This is really the first randomized trial in chondrosarcomas, and we're really excited to finally have a positive trial in a soon-to-be approved drug. So this is a DR5 agonist targeting the apoptotic pathway and the TNF receptor superfamily. This is a drug that had some preliminary signal in a phase 1 clinical trial presented a few years ago, showing specific activity in chondrosarcomas. There was some signal of hepatotoxicity that the company was looking at, although most of those liver-related AEs were low-grade. So the ChonDRAGON study was quite straightforward, with a 2-to-1 randomization of patients with metastatic or unresectable conventional chondrosarcomas. This was randomized to placebo, and then there was a crossover to the active arm. Because of the risk of liver toxicity, there was some surveillance around that, some caution around that, and so no liver conditions associated with an increased risk of hepatotoxicity were accepted on trial, and patients had to have a BMI of less than 30 if they were more than 65 years old. The population accrued in the trial was that was representative of a general population of patient with chondrosarcoma with a male predominance, and 30% of patients had tumors harboring IDH mutations. As you can see, this is a widely positive trial with a median progression-free survival of 5.5 months in the experimental arm compared to 2.66 months in the placebo arm, and a hazard ratio of 0.47 with a very positive trial here. All subgroup analysis showed a benefit of the experimental arm over placebo. Most common treatment-related adverse events were fatigue, diarrhea, nausea, some AST and ALT increase, although notably only 2.9 and 2.2% of those were of a grade higher than 3 or equal to 3. Constipation, asthenia, and decreased appetite. Most of those toxicity were highly manageable. Moving on to the targeted drugs that are currently under development for the treatment of sarcomas and that we'll keep our eyes on in 2026, but that are unlikely to be available in practice in the next year or two. Important abstract presented by Dr. Haddad at CTOS in Boca Raton in November on the role of TEAD inhibitors in EHE. Several TEAD inhibitors are currently under development, and this specific abstract focused on the VT13989 drug. EHEs harbor two types of translocations, both of which lead to activation of TEAD as the oncogenic transcription event. There are different types of mechanisms of actions that lead to the activation of TEAD across different tumor types, depending on the Hippo pathway. So LATS1-2 mutations, activating mutations, do also lead to activation of the pathway, and hence there are other tumor types than EHE that are targeted by those multi-TEAD inhibitors. In the current trial we are discussing here, there was first a 3+3 dose escalation cohort, and then several different cohorts. The one presented here is the EHE cohort, but other tumor types are of particular attention for the development of those drugs. 14 patients with EHE were treated on the trial. 5 of those patients had the typical WWTR1 CAMT1 translocation, and 7 did not have any translocation known or looked at before entering the trial. As you can see, once again, a quite convincing waterfall plot. There didn't seem to be a frank association between the type of fusion and the response to the VT3989. However, a quite impressive waterfall plot for those EHE patients who do not have any standard approved drug at this time. This drug was overall well tolerated, as you can see here. Specifically, almost no grade 3/4 treatment-related adverse events. Just one patient out of the 14 patients. Otherwise, other toxicities were grade 1-2, mostly fatigue, and the rest is listed on the slide. Focusing on desmoid tumors with the Foghorn trial, which is a beta-catenin inhibitor. Very interesting mechanism of action, as you know, and as we discussed earlier in the presentation today. In desmoid tumors, we've had gamma secretase inhibitors and Nirogacestat with impressive results a couple of years ago, leading to FDA approval. And so we're really excited to see other drugs now being developed. Very important on this trial is that although we're discussing data of only 12 patients on the phase 1, but most of this population was actually heavily pretreated. 9 out of 12 of those patients already had treatment with Nirogacestat. 50% of them had sorafenib, and 5 patients already had cytotoxic chemotherapy, which is really something we do only rarely nowadays to treat patients with desmoid tumors. The safety data is really impressive with overall very good tolerance, and we are extremely impressed with the results of the drug. As you can see, everyone had some form of shrinkage of disease in this very heavily pretreated population. Finally, the rise of ADCs in sarcomas. We've had already a little data presented around ADCs a couple of years, specifically focusing on osteosarcomas a couple of years ago at ASCO. This is the Artemis trial focusing on a B7H3 ADC. B7H3 is quite an exciting target for patients with osteosarcomas, but actually also other types of sarcomas such as UPS and LMS. In this trial, the authors were focusing on 3 types of cohorts: osteosarcomas in adults, osteosarcomas in the younger population of adolescents, and then other sarcomas, mostly soft tissue sarcomas. The efficacy in patients with osteosarcomas is quite promising. We'll be looking at this more closely once we'll have more data. This is data on only 15 patients, and there seems to be some response. We'll be looking more closely at how many of these patients had been pretreated with several lines of chemotherapy, or if this seems to be a cross-resistance with other chemotherapies. Very good median progression-free survival on this trial with 8.4 months of median progression-free survival with single agent on this ADC B7H3 in this population. However, it's unclear how many of those patients had several lines of chemotherapy. Looking at soft tissue sarcomas, 3 patients had some partial response out of 13 patients, which is promising, although we'd like to know what are the specific subsets of a soft tissue sarcoma accrued and which ones had a response. Was this associated with higher expression of B7H3 or not? The response rate of 25% is surely higher than other chemotherapies after 3rd line. However, we'd like to know once again how heavily pretreated this population was. The median duration of response was 5.7 months. We'll definitely be looking up for this drug not only in osteosarcomas but also in soft tissue sarcomas wanting to get a little bit more data and details on which patients will benefit of it. Once again, the efficacy in soft tissue sarcomas with a median follow-up of 19 months. There seem to be 53.8% of patients who remain on survival follow-up at this time. The median progression-free survival was 9.4 months. 6-month progression-free rate is 64 months. That's actually quite good compared to historical control. We will want to know, once again, number of lines prior to the ADC. And finally, what has been changing our practice in 2025? What are the novel drugs that are accessible in the clinic for patients with sarcomas? As a recap, Abemaciclib and Kaposi sarcomas, there's a use off-label, and there's also the NCI trial that is still enrolling. The response rate was 90% first-line setting, definitely better than all the chemotherapies that we've been doing in the past, although while tolerable, Doxil and Taxol are still chemotherapies, and we're excited to be able to give some Abemaciclib to our patients. We'll be excited as our second-line treatment is going to change in GIST with Sunitinib and Bezuclastinib second-line from the PEAK trial results. The Expanded Access Program is ongoing. I'll be discussing on the next slide the fact that the GIST treatment algorithm is about to change a lot, not only with the second-line trial, but there are a lot of new drugs on the horizon, and it's going to be complicated to know how to prioritize our different options. TDXD, trastuzumab deruxtecan, is already available now for patients with desmoplastic small round cell tumors, and we've been doing it off-label with or without expression of HER2 by IHC or by RNA sequencing, because once again this biomarker seems to be very imperfect for patients with DSRCT, and we'll be on the lookout for the COG trial to enroll patients with DSRCT. DR5 agonist, ozekibart, in chondrosarcomas, hopefully will soon be accessible based on this randomized phase 2 data. This is the first drug that has been positive in a phase 2 trial for patients with chondrosarcomas, so that's exciting news for our patients. What's coming up in 2026? Mostly GIST trials in the next couple of years. IDRX42, which is a pan-KIT inhibitor, trial is in second-line setting. There has always also been some arms in first-line setting. This drug seems to be quite effective, and we'll be on the lookout. There are also novel other mechanisms of action with combinations with imatinib, such as menin inhibitors, or novel immune combo of SOS1 inhibitors, where the KQB198 that we'll be looking up for. For those patients who have MTAP deletions, we're hoping to get together proposals with PRMT5 inhibitors, because there are at least 20% of patients with GIST who have MTAP deletions, if not more than that. And so we'll be looking forward to the development of PRMT5 inhibitors in patients with GISTs. We will be looking up for FGFR inhibitors in SDH deficient GIST. And finally, as with all other tumor types, we'll be looking for ADC trials, novel targets, combination of ADCs, combinations of ADC plus other targeted drugs. And I'd like to thank you for your attention.